October 4th, 2018, Healthcare MBA 607, Christian Brothers University, Case Study Analysis, Typhoid in Tajikistan by Martin Duclos. Tajikistan was formerly part of the Soviet Union, became independent in 1991, was devastated by a civil war that lasted until 1996 period. It is one of the poorest countries in Central Asia and is bordered by several other Soviet former republics, China, and Pakistan. Tajikistan is a beautiful country, but with limited economic resources. Increased health problems due to the lack of infrastructure and economic stability included increased exposure to infectious disease, lack of effective vaccination and access to vaccines, increase in food and waterborne diseases, malnutrition and vitamin deficiencies, lack of preventative and primary care, increased effect of chronic illnesses such as diabetes and heart disease with their associated complications, inadequate pre- and postnatal care, increased levels of violence and assault, and decreased attention to mental health needs, which can lead to increased suicide. Healthcare in Tajikistan was mainly provided at primary and urgent care centers from regional polyclinics. There was limited access to government-run hospitals, and the infectious diseases were monitored by the sanitary exchange services. Salmonella is caused by a gram-negative motile anaerobic bacteria, subtype Typhi. It is transmitted by the fecal-oral route and has an incubation period of 1 to 3 weeks. Typhoid was probably first described in 430 BC in ancient Greece and led to the death of leaders such as Pericles and Alexander the Great. The bacterial agent was isolated in 1880 by Karl Engbrecht and pathologists that worked with him, and a safe and effective vaccine was developed in the late 1800s by Almroth Wright and later adapted by Frederick Russell in America in 1909, which led to the use of the vaccine in military cases. There have been numerous outbreaks of typhoid throughout history. The plague of Athens in 430 BC killed about a third of the Athens population and led to the rise of Sparta as the predominant military power of the times. In the 1500s, in the Mexican highlands, there were estimated 7 to 17 million deaths that occurred due to typhoid. In 1600s, it is suspected that the Jamestown colony was widely affected by typhoid and may have been responsible for wiping out the entire colony. In the mid-1800s, the American Civil War saw over 80,000 deaths secondary to typhoid. One of the most famous cases was that of Mary Mallon in 1907 in New York City, otherwise known as Typhoid Mary. This case outbreak was not as large as the others. It only affected about 70 or 80 people, but it did cause significant panic and concern among residents of the city. Mary was a cook and had the ability to contact a lot of customers and therefore led to the outbreak. She was actually fired from her job and said that she couldn't come back to work unless she had her gallbladder removed. Her gallbladder was the source of infection that was able to be passed on from person to person. And she, rather than do that, decided to quit and then came back to work at the same place under a different name, went to work at other places, and continued to infect other customers. Reasons for her behavior were unclear. In Dushanbe, which is the capital city of Tajikistan, there were about 600,000 residents. Many of these residents had been displaced from other areas during the Civil War. and were associated with some overcrowding environments. Salmonella typhi was actually endemic to the area and had been for decades, if not centuries. There was an average of about 12 cases per week in 1996. This meant that the health professionals of Dushanbe in Tajikistan were somewhat familiar with the disease and were adept at identifying it and providing adequate treatment and control. By the end of 1996, however, cases had increased to about 75 per week, and there began to be some concern. During the period of January 29th to February 11th in 1997, 2,000 cases were reported, about a 100-fold increase above the baseline. All these cases were hospitalized at one of the 6 hospitals in the city. These hospitals were all run by the government and all run by professional physicians. The SES had to look and see what the possible causes of the outbreak were to know whether it was actually secondary to the infectious organism or whether there were other factors. Other possibilities could include reporting changes, if there was an increased level of surveillance or increased change in reporting process. This could account for increased diagnosis. There also could be increased migration to the area of infected patients from other areas, or a diagnostic error, simply laboratory testing that misidentified cases. All of these were ruled out. The symptoms of typhoid fever are fairly consistent. There's a slow rise in the fever. Later in the illness, it's typically rising in the afternoon and decreasing at night. The fever is associated with headache, bradycardia, cough, abdominal pain, and nosebleeds. During week 2, the fever becomes quite high as 104 to 105 degrees Fahrenheit. Fage sign is present, or Fage sign, which is a fever associated with bradycardia. Typically, fever causes increased heart rate, and in typhoid, there is a decreased heart rate. Also, delirium can be seen, and the characteristic rose spots and furry tongue of the disease affecting the skin and mucous membranes. In week 3, abdominal distension can occur. This can be associated with abscess formation in the intestinal tract, GI hemorrhage, diarrhea, which leads to dehydration, possibly perforation and peritonitis, progressive sepsis and toxemia, encephalitis, and pneumonia. The encephalitis is particularly disconcerting, secondary to psychosis and severe delirium. By week 4, the patients are either worsening and have a high rate of mortality, or they're getting better and able to survive. They do survive with a chronic carrier state and can lead to other infections even after they are improved from their own illness. Transmission of Salmonella typhi is via the fecal-oral route. Essentially, that can be passed from person to person by this method, or by eating fomites that have the infection, such as vegetables or water or other food-borne processes. This obviously is affected by hygiene and sanitation, and it can also be passed through the water supply and water system, as the bacteria does live in water and maintain its infectivity. Again, potential modes of transmission, person to person, is increased in crowded conditions, institutional settings, and under conditions of poor sanitation. Foodborne illnesses are common in seafood and raw vegetables, which may be contaminated and also passed on the waterborne route. The SES started an outbreak investigation at this time, and by the end of the initial part of the outbreak, 3,822 cases had been diagnosed. This was noted by clinical evaluation of skilled physicians to make the diagnosis based on clinical rounds, and isolation of Salmonella typhi from samples of stool, blood, or urine. The bacteria typically can be cultured in any of those medians, blood being the most sensitive, and that is the gold standard for diagnosis. There are other methods of detection, including TyphoidInTAjikistanPresentationQT, which is a PCR-based mechanism not available at that time, and what's called the Widal test, which is identifying antibodies to Salmonella. This probably was used during this outbreak. It's really an obsolete test now. It's been surpassed by more effective measures and is not a very highly sensitive test. It also has a fairly lengthy time to make the diagnosis. So they assessed also the demographics of the patient. The median age was 16, 51% of them were males, and they were fairly evenly spread throughout the city. The SES conducted index patient interviews. These were largely the first member of a household that was infected. They didn't really look at subsequent members since they assumed that the other members of the household were infected by the initial member, so that would not help them epidemiologically determine the source of infection. They interviewed them for recent travel. Very few of the patients had traveled outside the area. They assessed whether there were food purchased from street vendors. Actually, there had been previous minor outbreaks of the illness from street vendor supplied food in the past. That was one area that they were certain to look at. They assessed food purchased from government markets. About 90+% of the food in the area was purchased by this manner. They also looked at contact with other sick patients, which were fairly limited, and the use of the public water supply. They performed a case control study, which looked at a number of variables. These are the ones which are fairly significant. Drinking unboiled water had the highest matched odds ratio and very high p-value on that, with extremely high confidence intervals that drinking unboiled water was associated with infection. Using water from outside tap was also strongly associated. Eating food from street vendors was associated, but not quite as strongly. And the other factors of exposure listed here were protective, such as boiling water in the home and eating such things as apple, butter, onions, other fresh vegetables. Performing a multivariate analysis, they saw that drinking water from outside tap showed the highest matched odds ratio, over 16. Drinking unboiled water was also significantly associated with a high odds ratio, and eating food from a street vendor was significantly lower with a non-significant p-value. They also noted that eating apples and eating butter seemed to be a protective effect, but upon further investigation there was really no determination of why this occurred. It was theorized that perhaps patients that were eating more fresh foods and processed products were more well off, had higher socioeconomic status, and were less likely to have poor sanitation, but that's not been confirmed. Drinking unboiled water seemed to be the largest association. About 90% of index cases noted turbid or foul-smelling water from taps. The odds ratio increased with increased amounts of water. As you can see, one glass was 3 times more likely to be resulting in infection, 2 glasses 12 times, and greater than 2 glasses 40 times. There was also unknown assessment of why people would be drinking turbid water, especially more than once, but these are the results. Also should be noted that turbid is also cloudy water, and we'll discuss that in a few minutes. Thus, the investigators turned their attention to the Dushanbe water system. The system was largely that had been in place under Soviet rule, which historians of the Soviet Union look at centralized systems located in Russia as being advanced. The further away you got from the center of the Soviet Union, more outlying areas, particularly the Central Asian areas, received less attention and less resource utilization. In Dushanbe, there were 2 surface water treatment plants. These 2 plants were in the northern part of the city and essentially used canals to move water from the Varzov River to treatment plants and then into the distribution system. The Varzov River itself had the point of origin about 90 kilometers from the north, higher elevations, There were numerous villages along the way that had sometimes poor sanitation techniques and no access to municipal water supplies. Therefore, they often dumped waste products into the river, leading to contamination of the river itself. There were also 2 groundwater treatment plants which pumped water from wells to holding tanks and then directly into the distribution system. There was no real treatment of the water from this part of the water supply. Groundwater is generally less contaminated than surface water and usually did not require as much treatment or processing. Surface water treatment utilized multiple processes and multiple avenues for disruption. These include the variable quality of the source water, as we mentioned, into the system where coagulant is added to assist in precipitation of impurities. This leads to flocculation, which is accumulation of the impure debris, which are sedimented and placed at the bottom of the barrier. This is processed into the filtration system. Usually sand or other filters are used and removes those impurities. Disinfectant is generally added either before sedimentation or after filtration. Most commonly this is chlorine. Certainly chlorinated water process filtration and disinfection is prevalent in most areas of the world. The disinfectant containing solution is then passed through a disinfectant barrier where the finished water is released in a distribution system. In Dushanbe, several of these avenues were not working properly. The water supply itself had a high level of contamination from the river due to the upstream use of the river for getting rid of sewage from the small villages. There was actually no coagulant added, which made the disinfection and sedimentation process more effective. And there was no disinfection. About a year prior, the only chlorine manufacturing plant in Tajikistan had shut down, and the chlorination was not being done to the water supply. Flocculation processes in these plants were also inefficient, and sedimentation bins were filled with silt and algae. The filtration system itself was clogged with mud and iron oxide, and again there was no disinfection added to the end of the filtering process. The groundwater treatment plants were a bit better. The wells were in good condition. The wellhead seals were functioning correctly. The water intake itself was less contaminated. However, there were about 50% of the pumps not operational, which did lead to a bit of a lower water pressure. And if you think about how the system flows, if the water pressure is lower, it serves as more of a stagnant water supply, which can lead to increased multiplication of organisms. Water testing was done at the end of the treatment process and assessed the quality of the water coming out of the plants. As you can see from the picture, high turbidity on the right, low on the left. They also assessed fecal coliforms, that's the number of infectious agents that are in the water, and found surprisingly that there was essentially zero contamination of the water coming out of the plants, despite all the limitations of the process. Again, if you think about that water, a glass of water on the right, it's difficult to imagine how people were drinking multiple glasses of that water, but that did occur. So then the investigators turned to look at the distribution system of the water supply. In the northern part of the city, they got their water predominantly from the surface plants. In the southern part, the water was mostly from the groundwater treatment plants. In the central part of the city, the water supply was mixed. This actually did not show much of a change in the prevalence of infection in all areas. They seemed fairly evenly distributed. Since there were no predominance of infectious cases from different areas of the city, it was felt that the distribution system was the source of the outbreak. This was the pooled water supply from all the plants that was distributed into the individual homes. This system showed corroded pipes, breaks in the system, and low pressure, which all served to increase likelihood of contamination. In conclusion, the investigators looked at water from the faucets of individual homes and found that there was a high turbidity and high fecal coliform count at many locations from varying degrees. There was use of non-standard water lines and supplemental pumps used to offset low pressure. Because of the deficiencies of the distribution system as a whole, these were things that the population had done to sort of jury-rig the system to get better water pressure and supply, but they were not professionally done. The water lines were not insulated properly. They often were close to sewage containers and sewage drainage ditches, and any type of break in the water supply pipeline was able to be contaminated. There was also significant water wastage by the population. Water was essentially free, and so people didn't really consider it something to be concerned about. They often used about 1,000 liters per day. Some of this was due to breaks in the pipe and leakage, some was due to leaky faucets and in-home facilities, and some just due to general overutilization. This is about double the use of average American water usage per day. Prevention and control measures were then assessed for implementation. There was the goal of protecting the watershed of the Varzob River, extending upstream to limit the dumping of waste into the water itself. Repair and replacement of faulty equipment at the treatment facilities. Training of staff was necessary to monitor acceptable levels of purity. There actually was really no quality control measures in place from the water treatment plants at the time of the outbreak. They also looked at assessing the ability to repair and replace broken equipment in the distribution system, to fix the water lines, and to get rid of a lot of the temporary or substandard parts of the system. Obviously, to obtain adequate amounts of chlorine and coagulant, which was probably the most important factor, and public education regarding water conservation. Because of the significant cost of repairs, it was estimated that about $150 million would be needed to provide all these repairs and replacements, and the country certainly did not have that much money to put towards this. So they decided to look at point-of-use water treatment. They essentially said, we know you're going to get contaminated water in your faucets, but here's what you need to do to that water so you don't get sick. There are several types of point-of-use water treatment available. Boiling, which obviously requires a heat source. Chlorination, which is inexpensive and easy to use, just involve chlorine tablets placing into the water supply. Filtration, usually due to ceramic or micropore filtration system, was often expensive and hard to come by. Solar disinfection is actually cheap, but does take a while. It essentially puts plastic water bottles out in the sun and lets the sun disinfect them and kill the bacteria. Fairly effective, but does take a while to do. Flocculation, which is essentially adding coagulants and disinfection to a water supply. Procter & Gamble makes a packet that will do this, but it's a little bit expensive and does take both placing the packet in the water, letting it sit overnight, and then filtering it out afterwards. So that's also difficult to use. In 2002, they obtained World Bank assistance for Tajikistan and Dushanbe to phase in system repairs over 20 years. That process is still ongoing currently. There was also significant effort needed for public education to get the word out to the population about water conservation, the importance of maintaining a good water supply and a clean water supply to prevent infection, and using water treatment via chlorination or boiling. We talked a little bit in the case analysis about how to get the word out to the citizens of Dushanbe. There certainly was the ability to go door to door, of course, which was expensive and time consuming. They thought of using social media, which was in really its infancy back in the late 90s in that area, better today. They looked at distribution through government organizations, rallies, public platforms, churches and religious organizations, community leaders and community activists that getting the message out to people. There was actually a singer from Tajikistan named Shabnam Suraya who performed a song which is essentially talking about how to clean your dirty water. That was another way that they used to get to the population. Questions I thought about from this case study included, first, could similar outbreaks occur in the U.S., and why isn't the typhoid vaccine more widely used in an attempt to eradicate the disease? First of all, outbreaks like this certainly could occur in the U.S. Typhoid is endemic in the United States with about 600 cases confirmed per year, perhaps as many as 5,000 or 6,000 total cases. Obviously has a fairly low mortality rate with the use of antibiotics and the relatively good sanitation systems and water supplies that we have are very effective. What we have seen here occasionally with Salmonella is outbreaks from food areas, from certain restaurants or buffets or picnic areas that spread small numbers of infections. It's unlikely that there would be thousands of patients infected in an outbreak here because of our ability to identify, rapidly treat, and contain the illness, as well as recognition of the carrier state. For the second question, why isn't the vaccine more widely used? It's a pretty effective and safe vaccine. It's not very expensive. The general thought is that even if everyone was vaccinated, there is sources of infection in the environment that may still persist and can still potentially expose people. At this point, the cost of vaccination would certainly outweigh the cost of just treating the sporadic cases of illness that occur. So that's mainly a point of, can we eradicate the disease entirely with vaccination? Probably not. And how much more expensive is it to make the vaccine more widespread? Certainly we do offer vaccine to travelers to areas of higher concentrations of illness, but for the general population, the vaccine is not recommended at this time. Thank you for your attention to this presentation. This has been a terrific experience in this class. I learned a great deal, and I hope that this presentation was acceptable. Thank you very much.